Dr. Kofford, you ready to get started?
Bring it on.
All right, let's do this. Okay, so we're getting this started. You want to go to the next slide? Dr. Kofford's driving. All right, let's go one more. All right. Thank you everyone for joining us. Just a quick agenda here for everyone to get on the same page. We're gonna get through a lot of material. We're gonna start with some quick intros, some housekeeping, and then we're gonna dive into talking about the Omnibut. We're going to talk about how we developed it, really what it is and how it works. We're going to address all of that quickly, that portion, to make sure that we're all just on the same page. And then we're going to dive into the meat, which is the top questions that we are getting about the Omnibut. So as we go into that, you can see a few of the top questions we're getting there. And of course, towards the end, we're going to leave some time open for some Q&A, and then we will wrap things up. So that's a quick overview of what we're doing in the next hour here. So yeah, Dr. Kofford, if you can move us forward a slide. So some quick housekeeping. If you weren't aware already, we are recording currently, and we will be sending a recording of the webinar to everyone who's registered. So expect that in your inbox, most likely tomorrow. Now we do have a Q&A section. So we have a chat on the right-hand side. We'd love to hear from you in the chat. However, on the bottom, you see the Q&A. There's a little question box. If you click that, you can put in a question there, and you can actually upvote questions. So that makes it easy in case the chat starts going crazy for some reason. It makes it easier for us to know where the questions actually are. So we ask you to please submit your questions in the Q&A section there. Now we are doing we are giving away an Omnibut starter bundle today, and we will announce that at the end. So please hang around to the end so we can all be part of it. We can make sure you're here for that. All right, next slide. This is the man of the hour, Dr. Brandon Kofford. He and I talked about this yesterday. He told me I do not need to read off his entire resume, but he is going to be the main person speaking to you today, giving you all the info you want to know. He's one of the co-developers of not only the Omnibut, but also Smart Denture Conversions and more. I am Cameron Lanier. I'm the Director of Marketing, in case you're wondering, and I'm one of the people responsible for this change. So we are now Smart on X. You probably knew us previously as Smart Denture Conversions. We rebranded last year in August, I believe it was. We're the same company. We're still Smart Denture Conversions with a new name. We're the same people, same ownership, all of it. We're just now Smart on X. And the reason for that is we knew things like the Omnibut were coming. And since the Omnibut was coming, it didn't make sense to have Omnibut underneath a company named Smart Denture Conversions, so we rebranded to Smart on X, gave Smart Denture Conversions a bit of a refresh in the process. So yeah, we are Smart on X, and thanks for joining us. Next slide, Dr. Kofford. All right. So before we get started, I'm going to hand it over to Dr. Kofford here in just a sec. But I do want to start with a poll because we want to know what's most important to you in learning about the Omnibut, what matters the most. And so these are some of the questions we're going to be going through during this presentation. But I'm going to put up a poll here. And as I do so, I'm launching it right now. You should see it on your screen. We want to know, give you a minute here to vote. What is like the number one thing that you want to know about the Omnibut? And so give you about a minute. We want to see and make sure that we are spending the appropriate amount of time in this webinar and elsewhere in addressing the questions you have. So please do answer that question for us. Okay. About a third of you have already voted. Thank you for that. Give you guys a little more time here. Okay. Seems that people want to know how strong is the Omnibut. That seems to be one of the pressing things. If you disagree with that, now's your chance to vote. So please do so before I end this poll and we move on. We've got about 2/3 of you. If anyone wants to vote, I'll give you about 30 more seconds here. Maybe not full 30 seconds. I may have lied. All right. I'm going to end it in 5, 4, 3, 2, and 1. I'll share these results so everyone can see that 41% of you want to know about the strength of the Omnibut. And so I'm glad we have a nice long section prepared for you on that today. But yeah, we are going to be addressing almost all these questions. Now, if you did put other as your answer, please make sure that question gets into the Q&A. We want to make sure we can cover that. So please do get that in the Q&A section. All right, with all that said, I'm going to stop sharing and I'm going to hand it off to Dr. Kofford.
All right. Thanks, Cameron. So I just wanted to start this by telling you a little bit about how the Omnibut even came into being. And it happened, I want to say it was like February of 2021, maybe 2022. I think it was 21. My surgeon and I were in the operating room, and our one of our implant reps wanted us to try their brand new implant system. And we said, that's fine, but you have to bring all the components. We're not going to stock ourselves with new implant components. So you bring all the components and we'll use it. And this was a VME case, so we were chopping off a lot of bone, and we were going to lose a lot of the nice cortical bone that to stabilize and give us the primary stability we would need for loading. So I asked my surgeon, place 8 implants so that I just know that we're loading. So he lost count of his osteotomies. He drilled 9 osteotomies and we placed 9 implants. And so as soon as the implants went in, I get behind the patient and I start calling out to my sales rep, hey, I need a 30 degree, 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 a 30 degree straight multi-unit abutment. Silence from my sales rep. I look up at him and I say, what's up? And he just looked white as a ghost and he says, I have 2 17s and the rest are straight. Well, I wasn't too concerned about being able to do my conversion because, with smart edge conversions, it accommodates up to 70 degrees of divergence. So I knew I'd be able to do that, but I'd also have a 2.35 millimeter hole coming through the aesthetic surfaces of the teeth, which isn't ideal, but I'll change it after the implants have integrated and before we go to the final restoration. Irritating, but not the end of the world. So I do my I pick up my parts and I go into the next room and I start converting it. And my assistant, who is a Cuban trained dentist, he's trying to talk to me, but I'm just frustrated. I'm kind of frazzled a little bit and I'm frustrated. So I'm tuning him out, but he says, hey, doc, wouldn't it be cool if you could have like one abutment that does this, blah, blah, blah. And he just tried to describe an abutment that swiveled, and I just blew it off like, yeah, whatever. No, that wouldn't work, blah, blah, blah. So I just went about my thing. A couple months later, the engineer who helped me develop smart edge conversions is in the office with his mom, and I'm just, she's going to have like a denture reline. And Ray, who was assisting me, says, oh, Brandon, can I go talk to Charles about that abutment? And I was placing retraction cord or something like that. So I said, sure, Ray, go ahead. So Ray gets up and he goes and starts talking to Charles, and Ray doesn't have a soft voice, so I'm listening in on his conversation with Charles, hearing him describe it now in a situation where I'm not frazzled, and I get up from my patient, take my gloves off, and I turn over to the operatory, and I say to Charles, that's actually a really good idea. So that was how we developed the Omnibut. It was just because we were in the situation where I wish I had abutments that I just didn't have in stock. And that's a common problem. I talk to people all the time who are like, yeah, keeping an inventory of a straight multi-unit abutment, a 30-degree multi-unit abutment, a 17-degree multi-unit abutment. It's challenging. And sometimes I wish I had this one. And sometimes I wish I had something that was like in between a 17 and a 30 or whatever. And so that is what the Omnibut addresses, is both the inventory management, but also giving us much more options other than just a straight 17 or 30. So that is the clinical scenario that led to the development of the Omnibut. Smart denture conversions is actually pretty easy to develop because, the classification of the parts with the medical devices it's a class 1 instead of a class 2. implants and abutments are class 2 devices. So it's not a small thing to develop an implant or to develop an abutment and to get it through the FDA process. So this required us to expand our team and bring on 2 additional engineers, a mechanical engineer, Andrew. Andrew, you want to say hi? All right. So
Hi.
Andrew's our mechanical engineer. He's an incredible mind. And then we have Derek Conrad. Are you here?
Yeah, I'm here.
All right. Derek Conrad is a biomedical engineer, and I'm pretty confident to say that we could not have gone through the FDA 510(k) process without him. Derek, do you agree with that?
I think you guys would have gotten it done, but I'm glad to help along.
All right. So it was not a small process, and it took us about 4 years from conception to getting the 510(k) approved by the FDA. So we've put a lot of resource into developing this, a lot of time and a lot of testing. So we're going to go through that testing today and just show you kind of open up the curtain a little bit to what went into the development of this abutment. So what is it? What is this abutment? Here's a video that just shows it's a ball abutment with a swiveling attachment that looks like a multi-unit abutment. And this is the actual abutment close up. You see that you can use a driver to reorient the abutment to any angulation you want to. And that's the cool thing about it. You're not, I always call it the tyranny of the hex. You're not tied to the tyranny of the hex. You don't have to turn the implant in order to get just the right angle correction you want. So this abutment does allow us to go from 0 to 30 degrees and everywhere in between. It's made out of grade 23 titanium, which is the strongest titanium that we use in our dental implant restorations. Some implants are made out of grade 23 titanium, some are made out of grade 4. The grade 23 titanium is the strongest titanium. This is not a ball abutment. It is not for an overdenture. It is a multi-unit abutment that is attached to a ball abutment permanently. It does require at least 4 or more implants. You can't use this abutment for a single tooth. You can't use it for a 2 implant restoration. It has to be 4 or more. And the other point here is it allows for the ideal angulation. And that's a really big deal when it comes to full arch fixed. I see a lot of failures happening simply because of incorrect multi-unit abutment selection. And so this abutment allows for a much easier multi-unit abutment selection. So let's get into how it works. So here you see the 3 components of the abutment. Now, although this image shows the orientation screw and the swivel base and the Omnibut base that looks like a ball abutment, it shows them separated. The abutment is not separate. It comes fully assembled in a permanent way. You can unscrew the orientation screw from the swivel base, but the swivel base cannot detach from the ball. I mean, if you use incredible forces, you can detach it, but normal or even high human forces, you cannot dislodge the swivel base from the ball. Just a little animation here that kind of shows the process of selecting your ideal angle correction. So first you torque the abutment into the implant, then you loosen the orientation screw, redirect it with your driver, and then we have these orientation posts that are set at 15 millimeters high, which is really what you should have for restorative space in these all-on-X cases. And so you can use the opposing dentition to optimize the position of that screw channel from the multi-unit abutment. So I always say the screw channel ideally should be located in the central fossa of the posteriors and the cingulum of the anteriors. And you can use the opposing dentition to get there. So in this case, it's a mandibular arch. The posterior orientation posts should hit the lingual cusps of the maxillary tooth. And then the anterior orientation posts should hit the cingulum or just behind the cingulum of the maxillary anterior teeth. And if you do that, then your screw channels are going to be right in the occlusal table of the posteriors and the cingulum of the mandibular anteriors. So the abutment gets torqued to the implant according to the implant manufacturer's recommendations. So for a noble active conical connection, it's going to be 35 Newton centimeters. For Neodent Grand Morse, it's 32. For Straumann BLX, it's 35. And for Zimmer tapered screw vent internal hex, it's going to be 30 Newton centimeters. So you use the drivers that we supply, you use our abutments, but you follow the implant manufacturer's recommended torque values. Now, the orientation screw, the abutment comes assembled with that orientation screw in place with a little bit of tension on it. But when you're trying to redirect it, you just loosen the orientation screw slightly, use the T6 driver to get roughly into the right position. So here's what it would look like. You unscrew that orientation and then you tighten it back down when you're roughly in the right position. The driver is just used as an estimate. It's just going to make it easier for you to get the orientation posts in place. I like to use the orientation posts all on the abutments and then fine tune my position after I hand tightened with the T6 driver. So I have a lot of resistance. It's going to allow me to just fine tune that angle correction. At this point, you're going to provisionalize following whatever method you prefer. You can do conventional methods, you can do digital methods, or you can do smart edge conversions. It honestly, at this point, is a lot like a multi-unit abutment. When we get to delivery of the prosthesis, you'll see a slight difference than a multi-unit abutment, but you got to think about it as a multi-unit abutment at this point. All right, so how does it stay in place? It's all friction. So the question is, well, how rigid is that connection of the swivel base to the ball? Is it going to just be flopping around on me? Or, under load, is that going to have excessive micro movements? When I remove the prosthesis, is the abutment just going to be flopping around? And the answer is no, because it's not a floppy connection. The swivel base is attached to the ball in a permanent way with intrinsic resistance to rotation. So watch how the abutment, when we're going to use the driver to reorient it, but it's not like flopping around. You really have to use that driver as a lever to move it. It's even difficult to move it by hand. So we test the force required to move these things, and it is I don't want to say a significant amount of force, but there's a significant amount of force required to displace it, even when the orientation screw is loose. But it will hold its position even with the orientation screw loose, right? So you can see that it'll hold its position. And there's another video coming up that I'll show you that proves that point. So the orientation screw is going to put a little more tension into the system and give you a lot more rigidity to movement. So here you see this video here. With one abutment, you're going to have rotation 360 degrees around that ball. Look at how that prosthesis is held in its position. That's just the intrinsic resistance to movement that's in the swivel base. Now with two omnibuts connected, you have an axis of rotation. That's a 180-degree axis of rotation. But with three abutments connected, you have no axis of rotation. Do I expect there to be movement under function? No, because we have three or more connected abutment bases, and that's just geometry. The laws of geometry don't allow for axis of rotation once you've established a plane. 3 points of contact are a plane. And so once you have three abutments connected, you have no axis of rotation. Now, this is something that we had to prove to the FDA. There is no standard test to demonstrate micro movements in an all-on-4 setup. The FDA required testing, mechanical testing for abutments is for like single abutments. And so obviously if we test our Omnibut as a single abutment, it's in its contraindicated use. And we expect there to be 360 degrees of rotation under excessive forces. But in an all-on-4 setup, there's no excessive micro movements. Now, obviously, you're going to get deflection in the system, and we'll show you that. But there's no micro movement compared. If you compare the leading MUA, what we call the predicate device that we were telling the FDA that, hey, we are substantially equivalent to this multi-unit abutment. We tested that in an all-on-4 setup, and we tested the Omnibut in an all-on-4 setup. And we did it at a cantilever. We also did it in between implants. And so here at the cantilever, the force is pressing down, but in the anterior implants, you'd expect there to be lift. But the results show the leading MUA and the Omnibut statistically, no statistical difference between the two abutments or abutment systems. Derek, do you have anything that you wanted to contribute here?
Just a comment to anybody who's wondering what we're seeing on the graphs here. It's just the movement between the highest force and the lowest force. What we're seeing is gradual changes from temperature fluctuation just throughout the course of a day. This is a multi-day test, but we're not seeing any difference in the actual system movement over these millions of cycles. So from the traditional MUA or the predicate MUA to the Omnibut, we're not really seeing any differences, any statistical differences there.
Thank you, and that's right. So these tests are done to 5 million cycles, which is representative of, is it 5 years, Derek? Why 5 million cycles?
Yeah, depending on the study, you can see different studies predict somewhere between 5 to 20 years. Because it happens at about 12 times a second. It's to hit 5 million cycles. It's really accelerating that time. So this shows a lot of use, a lot of wear on these abutments, and they're really not moving.
And what was the force that we used for this?
This is about 325 newtons. So just under the average, or just around the average bite force of a mill from a mill.
Maximum, the average maximum bite force.
Yes, exactly.
Which is about 73 pounds. And that's a lot of force. And that's 5 million cycles at the average maximum bite force at 12 cycles per second. So we're very confident in the strength of this abutment and its resistance to rotation. All right, so but what about when you remove a prosthesis? Certainly all of us clinicians, rotation screw, you have a prosthetic screw, certainly something's going to loosen. Well, the reality is we just don't see that, right? So we tested these abutments at 5 million cycles, 325 newtons. And then here we have the bar that we made, which is meant to be really rigid. We didn't want there to be any force dissipated in the bar. We wanted all that force to be transmitted down to the abutment and implant connection. So we made this really beefy bar to transmit all that force down. And there's the abutments before, here they are after. They don't move, right? And then, well, what about loosening? Yeah, we didn't see any loosening of the orientation screws or the prosthetic screws. So will the Omnibuts move when you remove a prosthesis? We don't see it. And then, okay, well, what about my hygienist removes the prosthesis? And now my patient has a curious tongue, a very strong curious tongue, and they have curious fingers, and they're filling things in their mouth, and they're trying to move things. Is it going to move with their tongue or with their finger? No, it's not. you really have to have leverage on that abutment in order to be able to move it. And so that's what that driver and that orientation post provide, is that leverage.
So,
All
sorry,
right,
Dr.
so yes, sir.
So we do have a question related to this. What about torque check before the final? By doing this, can we move the position by accident?
So if you're talking about torque test of the ball abutment engaging with the implant, then no, you can go ahead and torque it, put the orientation screw back on, or reorient it back to its position. And then that's kind of the point of this slide right here is, let's say we moved all of these abutments to just try to re-engage the ball abutment, torque it, and now I have to get my prosthesis back on. Just kind of approximate them, and then use the prosthesis as a reorientation jig, and through the screw channel, you'll be able to engage that orientation screw and lock it back to that 25 Newton centimeter torque force. All right. So then we had some people debating online on social media, well, oh yeah, but you'll never get it to be passive again. And the reason why they say that is because they're thinking about non-indexed implant components. We all know that a non-indexed multi-unit abutment, if that abutment screw ever loosens and the orientation of that abutment is lost, you're a non-hexed position, so you're never going to get it reoriented properly. But with the Omnibut is different, and we have a schematic coming up. I'll show you what I mean. But we tested the passivity of fit after I made a model with implants. Then I put abutments in the implants. Then I made a prosthesis on those abutments. Then I removed the prosthesis. I removed all 4 of the abutments. I shook the abutments in my hand. Then I randomly placed the abutments back in implants, just trying to make sure that there was no way that I could get those abutments to the same implants that they came out of, right? So different abutments in different implant positions or different implants, and then use the prosthesis to reorient it. Then I embedded the whole system in acrylic and I cross-sectioned it. And what you see here is metal on metal. So here we have the tie base metal seating on the seat of the abutment. In this first image, position 1, you see we chipped in the process of cross-sectioning it. I chipped to the corner of the tie base. But if you look at the tilted angle, you can see that it's metal on metal. And then on position 2, 4, and 3, it's very obvious, metal on metal. This is passive. It is as passive as the prosthesis was made for the abutments. All right, so here's what I was talking about with those non-indexed abutments. The abutment screw is in line with the implant. And so if you use the prosthesis to position the multi-unit abutment, you have to remove the prosthesis in order to tighten that screw. And in doing that, the screw is going to move the abutment. Even 1 degree will make it so it's not passive. So it's impossible to reorient this type of a non-indexed multi-unit abutment for the prosthesis. But the Omnibut is different. Whoops. Sorry. The Omnibut is different. The locking mechanism of the abutment is in line with the prosthetic screw channel. So you can use the prosthesis as a reorientation jig, re-engage that orientation screw, and tighten it down if there's a need to do that. But there's not likely going to be a need to do that. So the only part that's moving is the swivel base in this action, right? So the ball abutment that's torqued to the implant is fixated. You don't have to retighten that to reorient the abutment. You just reorient the swivel base. All right, now this is the question that everybody wants answered, right? How strong is that abutment? Aren't you worried about the neck breaking? And that's the most common question we get. All right, so just so you know, in order for you to get an abutment through a 510(k) process, you have to prove to the FDA through data that your claim of being like a multi-unit abutment is evidenced by the data. So you can claim substantial equivalence to whatever you tell the FDA is your predicate device. So our predicate device was one of the leading implant companies, multi-unit abutments, and dynamic fatigue test, and it's referred to as the ISO 14801 2016, but we just call it the 14801 test. So the way the test works is you're going to embed an implant into a rigid material like bone or greater than bone. You have to simulate 3 millimeters of bone loss, and then you have to apply a force onto the abutment to generate flexure in the system, right? So you have to create a fatigue curve. And then once you've established that fatigue curve, you have to dial in where you get like 4 failures and 4 passing, or forces where 4 fail and 4 pass. Andrew or Derek, do you want to correct me on any of that? So this is what it looks like. So here we're applying a force to create fatigue in the system. All right. So what the FDA tells us is, hey, we are accustomed to seeing, in other words, our minimal acceptable load for these diameter of implants is this. But what's interesting is to think about, well, what kind of failures happen in that 14801 test? And how does that pertain to our clinical observations? So this is a patient that came to me. It was a failed all on 6, where the patient's right side, all 3 implants had failed. And so the clinician decided that they were going to spare half of the prosthesis and just put them into a removable partial denture. So here you see the restorative solution for the interim while they were recovering from the failed implants on the right side. Well, I suspect how this happened is, first the prosthetic screw broke. You can't see the broken fragment there in the tie base, but it's a broken prosthetic screw, which is difficult to recover from the multi-unit abutment. But if it's recoverable, great. The abutment is spared. But now we have forces on 2 implants that the system wasn't designed for, and so the abutment screw broke deep down in the implant. Very difficult to retrieve. And then now you have 1 implant holding the whole thing together, and sure enough, the implant fixture failed. I love this picture because it shows all of the potential failure points in implant systems. Now, you can also look at this in single unit restorations. I've seen implants break. I've seen abutments break, the hexes break. In full arch restorations, I've seen abutments split in half, and I've seen implants split in half. Now, all of these usually come from a poor design or violating principles that that led to their demise. Okay, this is a case I treated just yesterday, and my partner treated today, recovering broken or failed implant components. So in the X-ray, you see a bicon implant with a fragment still in the chamber of the bicon implant. It's not a screw. It's just a friction fit, right? So I have to just retrieve that fragment. So I do that. I drill into it, and then I use an extractor tool. I break the tension, or not the tension. I break the force, the retention force on that component, and then the fragment comes right out. A stripped screw, an extractor tool is very easy to use to remove that stripped screw. An abutment fragment in the implant, use an extractor tool to pull that out. But when something breaks deep into the implant, it's a lot different story. It can be impossible to retrieve. Here you see an implant that was referred to us, hoping that we could recover the broken screw fragment deep down in the screw channel. In this series of X-rays, you don't see the original thread, you only see that I've drilled through the threaded component deep down in the implant. And now I'm going to try to use the extractor tool to remove it. So I use a fine extractor tool trying to get that fragment, and sure enough, the tip of the extractor tool breaks off in the threaded broken fragment in the implant. Well, now it's impossible to drill through. So I can't spare the implant. We back the implant out and place a new implant. This is the patient's fourth attempt at this implant. She's super frustrated. But my point here is things break, and you just have to have a plan for when things break. Now, back to the Omnibut, how does it perform? It performs better than the minimum standards required by the FDA. In fact, almost double in most cases, most of the implant systems that we did, the minimum force requirements by the FDA in order for us to claim substantial equivalence. In conversation with one of the major implant companies to which we do claim compatibility, I talked to their vice president of research and development, and I asked him, when you do your 14801 test, what do you see breaking? And he said, well, what do you think breaks? And I said, well, I would guess that that prosthetic screw, being the smallest and weakest component, is what breaks. And he said, nope, it's not the prosthetic screw. And I said, okay, well, then I'd expect the abutment to break. And he says, nope, it's not the abutment that breaks. I said, you mean to tell me it's the implant that breaks? And he said, almost every time it's the implant that breaks. So the weak link in this system is actually the implant. All right. So in addition to strength test and mechanical testing, we also tested retention force of that swiveling component. We tested cytotoxicity, so to make sure that our manufacturing processes were safe for human cells. We validated our sterilization. We did that simulated all-on-4 testing. We did our implant compatibility. We provided our implant compatibility methods. And what was interesting was the FDA, there was a periodontist on the FDA panel who was really worried about the cleansability of the abutment. And at first I was like, what do you mean the cleansability of the abutment? And she specified, how is a patient going to clean this abutment? And I was flabbergasted. I was like, well, the same way you clean any abutment. So we had to do a patient hygiene test. Cleansability of the abutment is actually more dependent on the prosthesis than it is the abutment. It's the clinician's responsibility to make the contours of the prosthesis cleansable. Failure to do so leads to hygienic failures, regardless of the abutment used. So here you see on the left an all-on-5 case. This is the patient's final zirconia prosthesis, and you can see that the patient is attempting to keep that thing clean. The flanges of that denture are clean, meaning she's flossing underneath it. But the floss isn't connecting with the concave contours of that intaglio of that prosthesis. And that's on multi-unit abutments. On the right, you see a prosthesis that was done directly to the implant fixtures, and there is no way that the patient can keep that clean. This isn't because the patients are disgusting or the patients are negligent. It's actually because the prostheses do not allow for cleansability. So here you see another case with the standard multi-unit abutments, but if the prosthesis doesn't allow for cleansability, then the abutments are not cleansable. It's the prosthesis that limits the cleansability of the abutments. So it was difficult for us to conceive of how to test this, but we just kind of made a worst case scenario. You see a little bit of space above the gingiva, food's going to get stuck underneath there, and so the occlude spray is simulating food and plaque and anything sticky that sticks to that surface. And if anybody who's used occlude, you know that it doesn't just wipe off, right? You've got to really work at it to get that occlude off. So we use the occlude to simulate plaque, right? And then we brushed it, we flossed it, we used interproximal brushes, and we water picked it. And sure enough, the abutments come out very clean, all surfaces of the abutment. And it's comparable to the predicate device because we had to do it for both the Omnibut and the predicate device, which is the standard multi-unit abutment. All right, so then now a lot of people want to know, okay, what are you compatible with? We went for our first 510K was for the major implant systems that we're familiar with that are used in all-on-X type cases. So that's the Neodent Grand Morse taper, it's the Nobel conical connections, narrow and regular platform, it's the Straumann BLX, and the Zimmer internal hex. So here you just see an image of all of those connections. All right, so what we'd love to hear from you, and if you could just put this in the comments or in the Q&A sections, is what implant platforms do you not see that you wish we did have it for? All right, so now another big concern that people have is, oh my gosh, why did you change the prosthetic screw channel? Why did you change the prosthetic screw? Why didn't you stick with the M1.4 by 0.3 threads? It was a functional necessity. So the driver that engages the ball to torque the abutment to 35 Newton centimeters has to be beefy enough to be able to withstand those torque forces without breaking, without deforming. And so we tried multiple drivers in order to accommodate this. You see the 050 hex, we tried a T5 Torx, we tried the T6, we tried like the pre-unigrip driver, and it just worked out that in order to have a screw channel wide enough to accommodate a driver strong enough to torque the abutment to 35 Newton centimeters, we had to open it up to an M1.6 in diameter. Okay, well, that's great. An M1.6, MIS has an M1.6 prosthetic screw. Okay, so why didn't you just stick with an M1.6 by 0.35 thread pitch? Why did you do it to a 0.2 thread pitch? Well, the 0.2 thread pitch opens the screw channel up just ever so slightly enough that we could get a Neodent spline drive feature down to the ball abutment without having to carve into the threads of the orientation screw. So it was a functional necessity for us to change the prosthetic screw for this abutment in order to optimize the performance of the abutment. All right, so it does require an M1.6 by 0.2 thread. And here you see the spline driver that engages the ball is slightly narrower than a T5 Torx feature. The T5 Torx feature was too thin and it would deform under 35 or up to 50 Newton centimeters of force. So we couldn't use a T5, we needed to bulk it up to the Neodent spline. The Neodent spline was narrower and it fits perfectly through an M1.6 by 0.2 thread pitch without having to carve into the thread pitch in the orientation screw. All right, so now let's get to the clinical evidence. This is a fun part. This, for me, has been a fun evolution. So I just want to tell you about Lorna here. Lorna, I haven't been doing a lot of surgeries, right? I started back in 2019 is when I started doing surgeries, and Lorna was my first patient. And because she was my first patient, I wasn't sure my implants were going to integrate, so I convinced her to, well, I mean, I told her I was going to place 7 implants just in case some of the implants failed. I'd still have enough to retain an overdenture. So in August so that was back in 2019. Here you see in August 2022, she went from maxillary complete denture over mandibular overdenture to a maxillary fixed. So August 2022 is when I did the surgery in her maxillary arch to go fixed, and then she was an overdenture in the mandible. Well, a couple months go by, and Lorna says, man, I really love this upper fixed. And I said, Lorna, how would you like to go fixed on the lower? And she said, I'd love to, I just can't afford it. I said, Lorna, I have this new abutment and I love it, but I've never used it on a patient before. How would you like to be the first one? She says, I was your first surgery patient. I'd love to be your first Omnibut patient. I said, awesome. So in February, I take out all of our locator abutments and I replace them with these Omnibuts. And this was our original version 1.0. I had some frustrations with version 1.0. So I got through it. But before going to her final restoration in January 2025, I wanted to swap out all of her uh, version 1.0, which had some frustrations, to our version 2.0, which are awesome. And so here I have a prosthesis that was made to version 1.0, and I'm swapping all those abutments out for version 2.0 and delivering the prosthesis. Again, just proving that the abutment will auto align back to the prosthesis. The prosthesis is the reorientation jig. All right, so this is what it looks like. This was a guided case I did. I can't remember when. You'll see in the panoramic, but I place these abutments at surgery. I torque them down to 35 Newton centimeters, and then we reorient them and make a prosthesis. I use SmartEdge conversions because it's super easy. The patient's loving it. So he's a maxillary complete denture over mandibular fixed. Again, this was a charity case I did, and he loved it. But here in December 2023, you see a 2-month post-op, so that must mean that I did this surgery in October. In April, we delivered the zirconia prostheses of April of 2024. And then in November 2024, we remove the prosthesis, we do our cleaning, and put the prosthesis back in place. But you can just see how the bony contours really aren't changing. Here you see another case we did early on, January 2023. She presents for consultation. July, we do the surgery. In June of 2024, we deliver her zirconia prostheses, and in March, we do our follow-up, and we just see that the bone is not moving. Now, granted, these are short-term studies because, I mean, we've only had the product in my hands since when was that? I want to say May of 2022, but I didn't use it on Lauren until February of 2023. And then here you see another case. This is an all-on-4 case, right? So 4 is the minimum number, but you can go up to 7, 8, 9. I don't care. Again, all-on-4 case. And we just see the bony and soft tissue contours just seem to really like these contours of the abutment. Again, speaking to the cleansability of the cleansability of the abutment. If the prosthesis is cleansable, the abutment is cleansable. Right? Another case, surgery done in November 2023, delivery in March 2025. No, that was a follow-up in March 2025. The surgery in October of 2024, and then follow-up in January of 2025. And then this one was just 2 days ago that we did her follow-up. Or no, sorry, that we did her delivery of her zirconia prostheses. Now this one's really interesting because everybody's worried about the orientation screw loosening. And I always tell people it is not necessary for that orientation screw to stay tight. It's not even necessary for it to be the orientation screw is not even necessary. So if you look real close at these abutments, these are our version of the Omnibut that don't even have an orientation screw. These aren't commercially available. We were just testing it out. And I really like it. It's super clean. The orientation screw is a clinical convenience, but it is not a functional necessity because the prosthesis is the rigid splint that holds them all together and doesn't allow for any kind of micro movement or any kind of axis of rotation. So that's a real whirlwind presentation on the Omnibut and what it took for us to get it to you guys, available to you guys. And with that, I'm going to open it up to question and answer. Cameron, I'm going to turn the time back over to you to just kind of.
Sure. Yeah, so the first question, what implant system did you use for these case studies?
Oh, great question. So I used the, Lorna was a Blue Sky Bio Biomax. Um, some of those were Nobel regular and narrow platform. Some of them were the Zimmer internal hex, and I don't think we did any on the Neodent or the Straumann BLX. We did have a clinician use them on the Neodent. So anybody who knows Safa Tomasebi, he used it on the Neodent Grand Morse taper. Um, so I think the Straumann BLX is the only one that I personally haven't used clinically. But that doesn't really matter at the point that they're delivered. It's a multi-unit abutment. It's the same.
Okay, cool. So we have a number of questions here. So um, can we use this abutment with locators for Hyacin Implant Direct and Straumann implant as well?
All right, so that's where the FDA is going to require us to say we are um, compatible with Nobel conical connection, narrow and regular platform, and we are compatible with the Zimmer internal hex. We are compatible with Neodent Grand Morse taper, and we are compatible with Straumann BLX. Full stop. Now, clinicians, if they choose to use our abutments off-label with a system that they know to be compatible with the ones that we claim compatibility with, that's totally up to the clinician. But we as a company, we claim compatibility with Nobel conical connection, Neodent Grand Morse taper, Straumann BLX, and Zimmer internal hex. Now, as far as the locator goes, this is not, I mean, this is a replacement to a locator. You wouldn't use it on top of a locator. And then what was the other question? I thought implant direct.
Yeah.
So I don't know if everybody understands the history of these implant internal connections, but Gerald Nisnik is the inventor and patent holder of the internal hex. He is also the founder of Implant Direct, which uses that internal hex that he owns the patent for. He sold the rights to the patent or licensed the rights of the patent to Zimmer. So the Zimmer internal hex is Gerald Nisnik's internal hex connection.
Right. Early question. I would like to know how to transfer the abutment's positioning from a master cast to the mouth for accurate positioning and prosthesis 4.
You're gonna have to repeat that question one more time.
Yeah, I would like to know how to transfer the abutment's positioning from a master cast to the mouth for
Ah,
accurate positioning.
yeah, okay. So I think what you're asking, and whoever asked that question, it's a great question. Um, Correct me if I'm interpreting it wrong, okay? But I think what you're asking there is, okay, I've made an implant level impression. And now my laboratory is selecting my multi-unit abutments and placing them on my master cast and making the prosthesis on that master cast with the multi-unit abutments to the implant analogs. So now my job is to go back to the patient's mouth, remove healing abutments or locator abutments or whatever's there, remove healing abutments, and place the abutments that were on the master cast in my patient's mouth. And now how am I going to reorient it to the prosthesis that was made on the master cast? So I believe that's the clinical the design of this abutment. The prosthesis is the orientation jig. And so I had a case where it was an implant, it was a bar overdenture, and I had a multi-unit abutment, just a standard multi-unit abutment in place on the right posterior implant, distal angulated. 3 implants that I did an impression, an implant level impression, left the multi-unit abutment in and did a multi-unit abutment level impression, implant level impression, implant level impression, implant level impression. And then my laboratory designed a bar with Omnibuts on those implant level impressions. So then I had to transfer from the master cast to the patient the Omnibuts that were on the master cast. And then I loosened the orientation screws, placed the bar, it oriented the abutments to the proper position. Through the screw channel of the bar, I engaged the orientation screw, locked it, or torqued it to 25 Newton centimeters, and then screwed it in, no problem. So it goes back to that question, the prosthesis is the orientation screw. And that's if I interpreted that question correctly. So whoever wrote that question, great question. Please correct me if I interpreted it incorrectly.
That was from Craig, so thank you, Craig. Okay. And yeah, feel free to let us know if you need a follow-up on that. All right, you've kind of addressed some of this, but what has been seen in regards to bone/tissue growth and that negative space between the base of the MUA and pivoting part?
Yeah, that's great. So I've been placing my implants at the crest. So I'm not seeing bone grow up over the implant, but I am seeing it stay put for the most part. And then the tissue just fills right into that space, right? So you think about tissue as a fluid-filled sac. It just flops into the space. And so we have this image where you can see the soft tissue around that abutment. And a lot of this comes to surgical technique, making sure that you maintain good keratinized tissue around the abutments. And then you just get this really nice seal of soft tissue around the abutments. I asked my hygienist today, right before coming here to do this presentation, she did a couple follow-ups on patients with Omnibuts today. And so I asked her, how do you like those Omnibut abutments? And I just wanted her candid feedback. And she said, I love them. The tissue looks so healthy around those abutments. So the tissue just fills right into that space. It's pretty awesome.
Cool. All right, I know we're at time, but we want to get your guys' questions in here. So please feel free to stick around and so we can get a few more questions in. Let's see. Andrew, did you have one you wanted me to highlight? I'm sorry.
Yeah, there's a question here. Are all the abutment heights the same or are there different cuff heights? And we kind of had that question 3 times.
Great. So I'm a big believer that I only need one multi-unit abutment tissue height, and that's 2.5, right? So in my practice, I only ever use one tissue height, a straight 2.5, a 17 2.5, and a 3.5 30. Now that's in reference to the long portion of the abutment, not the short portion of the abutment. So why a 3.5 30 and not a 2.5? Geometrically, it doesn't even exist. You can't have a 2.5 long wall on a 30-degree angle corrected multi-unit abutment. So it's the shortest 30-degree multi-unit abutment there is, and then the shortest 17-degree multi-unit abutment there is. And then the 2.5 straight is just to keep it standard. And that's just because of tissue thickness, right? So the average biologic width for the human is 2 to 3 millimeters. So 2.5 is right between them. That's all I ever use. So and you can blame me for this, but we only have one tissue height, and that's a 2.3 millimeter tissue height. So when you go from a straight orientation at 2.3 and you swivel, well, this side gets closer to the bone and this side gets further up, right? So, and it just depends on the angle of your correction. And Derek, you did some drawings that show the various heights, the short wall and the long wall in different orientations. Do you happen to remember what those measurements were?
Yep, I've got them right here. We have for at 30 degrees, the short wall is a 1.1, where the long wall is a 3.5. So again, it just shows what you were saying. It's the shortest possible at 30 degrees. At 15 degrees, it's 1.7 on the short and 3.0 on the long.
Okay. Great. Now, we are developing, but it will require another 510K, but we are developing a taller tissue height. And that was specifically in response to Safa Tomasebi's preferred implant placement technique, which is subcrestal. So he just wants more runway to get out of that subcrestal implant position and get that angle correction without having to do too much bone profiling. Is that correct, Derek?
That is correct. We're working on getting those up and ready and getting it ready for the same bout of tests that we did on these. Our goal is to get them to the FDA as soon as possible.
Yeah.
All
Cool.
right. We have from Donald Dinello, if I'm pronouncing that correctly. I hope.
Hey, Donald.
We have, when do you anticipate having the scan bodies ready for the Omnibut? At this moment, we have to take an implant fixture level impression, or should we always use an implant fixture level impression?
No, so I actually don't do implant fixture level impressions. I always do a multi-unit abutment level impression. And so you could use, we have Omnibut multi-unit abutment, sorry, Omnibut impression copings for a conventional impression, but we also have digital scan bodies for a digital workflow using an intraoral scanner. Or you could also just do a copy mill of the prosthesis. I'm a big believer that the provisional restoration, man, you just focus on making a beautiful provisional restoration, then getting to the final is super easy. You just copy it. So you can put some prosthetic scan bodies on the prosthesis, scan it, and your design is done. You're ready to go to the final. So we are planning on making the DME files available for that digital process within the next month and a half to 2 months. JJ, you got that?
All right.
Heard you loud and clear.
Sorry, we still got a few questions, but before we jump to another question, I feel like because of the time we're at, let us get through a few more slides just to kind of help wrap things up. And anyone who wants to stick around for some more questions, we can stick around for those questions. But Dr. Kofford, if you don't mind advancing us, we wanted to show you guys real quick that we do have Omnibut starter bundles if you haven't seen them already. So these are a couple bundles. There's one that includes some SDC kits. And it includes 2 of them, and you only have to pay for 1 of those kits. Both bundles will give you pretty much everything you need to get up and running with the Omnibut. And so we're trying to give you the drivers and everything you need. Now, as a thank you for coming today, we also wanted to offer you a coupon code, Omnibut101, which will give you 20% off all Smart on X products on our site. It's only through our website, and that expires April 2nd. So please remember that, Omnibut101. We'd love for you to take advantage, and we'd love for you to use that as an opportunity to get started with the Omnibut. So yeah, we also did... we do have we want to start doing more webinars. And as a result, we want to get your feedback on what's the webinar that's going to better answer your questions. So I want to launch a poll real quick and get your feedback, if you don't mind. We have 3 ideas that we're throwing out there right now. And the first being, what does digital look like with the Omnibut? Let me launch this real quick. So for our next webinar, please feel free to vote what you would like to see. What does digital look like with the Omnibut is an option that we're looking at. We are big TV fans here. So Mythbusters, we're talking about doing busting myths about all on X, and on-ramps and off-ramps. We are big on a more efficient and predictable all on X workflow. As you can probably tell, we like to do all on X smarter. So as a result, we have a few webinars we're thinking about doing, and we'd love to get your input on that to make sure that we're helping answer your questions. So if you don't mind, we'll give you guys about 30 seconds here to get that answered and help us out, and we appreciate that. I know which one Dr. Kofford wants to do. Give you a few more seconds here. Appreciate. And we will get back to a few more questions for anyone who wants to stick around. We're happy to answer some more questions if you want to stay. Okay, give this about 15 more seconds, then I'll end this poll. So get in those votes if you haven't already. 5, 4, 3, 2, and 1. I'll share these results for everyone to see. So thank you for sharing that. I'm not promising what the next webinar is going to be based on these results, but we appreciate any feedback we get. It helps us to know how to better answer your questions and meet your needs. So thank you again. Also want to very quickly, if we can go to the next slide. We did promise that we would be giving away a starter bundle, and so we want to award that today to Scott Phelps. So thank you,
That's
Scott.
a big prize.
It's a big deal.
That's
So
a big prize.
yeah, so we're giving you not just the starter bundle, but the starter bundle that also includes the SDC recharge kits. So Scott, we'll be in touch and we'll be making sure to get that to you. So we will send you an email, give you a phone call here in the next day. Okay, with all that done, I want to make sure anyone who still has questions, we take the time to go over those questions. So Andrew, JJ, Derek, feel free to jump in here and help me highlight any of the questions we got. We've got quite a few and some in the chat as well. Let's see. Can Omnibut be used with zygomatic implants?
So that's a good question. We haven't tested that. Zygomatic implants have their own dynamic, but a lot of zygomatic implants use the same connections. Like the Neodent zygomatic implant has the same connection as their dentoalveolar implant. Norris, which is an internal hex, or they also have a conical connection. Their zygomatic implant has the same connection as their dentoalveolar implants. So I would have to say that we haven't done a zygomatic test to validate that. Theoretically, I would think that the Omnibut wouldn't pose any more risk to a zygomatic implant than any other abutment, but I look forward to testing that. I will tell you that we are currently working on a zygomatic solution for a leading zygomatic implant manufacturer that uses an external hex that gives you a 55-degree angle correction in the platform of the zygomatic implant. So you'd really you'd have 85 degrees of angle correction from the axis of the zygomatic implant. But again, that we're early in testing that or developing that.
Gotcha. Are your MUAs compatible with any PG units?
Are the MUAs compatible with any PG? Oh, photogrammetry. Okay. Yeah. Okay.
That's from Bruce Smoller.
Sorry, I'm a father of 6 young children. When I hear PG, it's the movies we watch. So we are currently working with PIC, iMetric, Micron Mapper, and Shining 3D. And there's some others. I forget their names. I'm sorry if you're watching. I'm so sorry that I can't recall right off the top of my head. But we're currently in development of just the screw that retains the photogrammetry flag to the abutment, because that's all that's needed. The platform, the cone, it's a standard multi-unit abutment, like the industry normal or industry standard multi-unit abutment geometry. So with iMetric, for example, you can remove the screw out of their flag and then replace it with our screw, and then you'll be able to do photogrammetry. Same thing with Shining 3D, same thing with Micron Mapper. So the M1.6 threads of the prosthetic screw require a larger opening. So if you only have an M1.4 scan or photogrammetry flag, then the screw won't fit through the aperture for the photogrammetry flag, or for the screw that retains the photogrammetry flag. So those are some of the issues that are currently in the works, and that's what we'll have ready for you when we talk about what does the Omnibut look like in the digital workflow.
Excuse me. So somebody asked about
And by the way, sorry, the things that we're going to be able to do with the Omnibut and the digital workflow are really, really exciting. So those of you who just really love your digital workflow, what we're working on is going to be really cool. I can't wait to show it.
it's coming. Yeah. Somebody asked about screw fracture and retrieval.
Screw fracture and retrieval of the prosthetic screw, or are you talking about the abutment screw in the implant? So let's talk about prosthetic screw fracture. First of all, I don't anticipate that to be an issue because of the larger diameter and the finer thread pitch of the screw. It's a stronger screw than the M1.4 by 0.3 screw. Andrew, you're the
We're
mechanical
asking
engineer.
about the abutment screw. Sorry.
The abutment screw?
Yeah.
So the abutment screw that's engaging the implant, that's not likely to fracture. But if it does fracture, you have to retrieve it the exact same way you retrieve any other broken abutment screw. So you have to drill into the screw wide enough that you can then engage an extractor tool to reverse it out. Or, I mean, if it's just loose, once an abutment screw breaks, then the screw is no longer under tension. And assuming that you don't have any cold welding or you don't have any burrs in the screw, then sometimes you can just back it out with like Explorer tines or sometimes you can even use a cotton tip applicator, the wood part of a cotton tip applicator, stick it down in the implant and try to just spin it out. So you treat it like a broken abutment screw. But that's not likely where the failure would occur.
No,
If
and
there's
I
going to be a
stopped you from
failure,
answering the other question if you did want to finish that thought.
if you're going to see a failure, I'm pretty confident you're going to see the failure at the neck, which is awesome because it's not likely going to happen. Under our testing conditions and my clinical observations, you are not likely going to see it fracture. However, if it were to fracture because of misuse or poor engineering of your prosthesis, if it's going to fracture, it's most likely going to fracture at the neck, and that's at the top of the implant. So it's a lot easier to retrieve fragments that are broken at the top of the implant than fragments that are deep down in the implant. So that's actually a benefit.
Now, somebody also asked, it was back when you were talking about some of the clinical evidence. They were asking about the differences between Omnibut 1.0 and 2.0, if you want to speak to that at all, maybe some of the development.
Yeah, so you saw that video that Cameron made of him swiveling around the one abutment, and then he let go of the prosthesis, and it has that intrinsic resistance to rotation. That is what we made in the 2.0 version. The 1.0 version, the assembly of the and I can't give too much away because it's all proprietary, but the assembly made it so that we couldn't have that intrinsic resistance to rotation, and you only had resistance to rotation when the orientation screw was tightened. So 2.0, that swivel base, it's locked in position. It has that intrinsic resistance to rotation with or without the orientation screw. So that was the real huge improvement from version 1.0 to 2.0. Clinically, it just makes it so much better.
Well, I think we got through all the questions. So thank you everyone who submitted those. We appreciate your time tonight. And please feel free to email us questions, give us a call. We're always happy to help wherever we can. We will be sending out, like I said, a recording of this, so please make sure you're checking your email for that tomorrow. And thanks again for joining us tonight.
Yeah, thanks everybody. It's been fun for me.
All right. Have a good one.
So yeah.